Thank you very much, Lillian. Good afternoon, ladies and gentlemen. I am going to join Professor Mayanja in confessing that nobody particularly gave me any guidance in coming to give this talk. I was told to come and just say anything about opioids. So you've got to take what I have to say. I have had a few questions get passed over to the psychiatrist. I'm happy to address them after this because I spent some time doing this. All right. I'm Raymond Odokonyero. I'm from psychiatry, and we want to talk a little bit about the neuroscience of opioids. That's what the outline of the talk would look like. Now, opioids are not a new thing. Since the 70s, we've been experimenting with different types of opioids. And that term itself is quite a blanket term. But first, you must look at that diagram and get a little bit worried. Worried because previously that small country, that small continent with 6% did not feature in that Venn diagram. And now, it's 6% and growing. Africa used to be a transit route for opioids from Asia and elsewhere. Now we have become a destination. So that's why that percentage should worry us, and it's going to continue to grow. The group of drugs that we call the opioids. Opioids is actually a blanket term referring to both opiates and then the synthetic and semi-synthetic compounds that act in an opiate way. So when you talk about opioids, you're talking about a class of drugs. When you talk about opiates, then you're talking about those things we are giving on the ward, the morphines, the codeines, the peptides, and the like. It comes from that very beautiful plant there called Papaver somniferum. Very beautiful, with a dark brown sap from which we get all these interesting ingredients to create the opiates. And after you've picked them up, then you can have the luxury of classifying them. You can classify some of them as being pure agonists. Those are the ones on the extreme end there. Or you could also create the synthetic ones, the heroines, the morphines. By the way, morphine comes from heroin. So play around with morphine a little bit, and you'll get, play around with heroin a little bit, and you'll get morphine. And then, of course, we have the newer ones there, whose real use we shall see in a little while. Now, talking opioids, we are talking about receptors that we are born with, we have grown up with, and they are everywhere. Most of it is in your brain. And there are three receptors that you want to remember: the mu, the kappa, and the delta. Let me reverse that order. Start with mu, delta, and then kappa. The kappa is on the extreme end because it will oppose everything the mu and the delta are doing. The mu is on this extreme end because it's the very worst there is. Like having mu receptors alone is enough for you to develop all sorts of interesting outcomes when you take opioids. So that's what is happening in our bodies. But the receptors are already there because our bodies needed them to be there. It's kind of the way we have receptors for say dopamine in your brain. It's because you need to feel love, you need to eat food and feel happy and feel some joy in life. The same thing happens with these opioid receptors. We already needed to manage pain and to feel relief. So because we have endogenous opioids inside of us, those receptors were there for that exact reason. But over the years, we have come up with exogenous opioids, and that causes problems for us. If you did a PET scan, the red would be opioid receptors in your brain, especially the mu opioid receptors. So what is this mu opioid receptor business? The mu opioid receptors what are responsible for the reinforcing effect of the analgesia that you're giving your patients. So that means if you should give the patient some morphine, they are going to feel the need for more morphine. That feeling of requiring more morphine is driven by the mu receptors in the patient's brain. And in fact, it is that reinforcing property that makes someone more likely to demand for more, makes somebody more likely to fake prescriptions, to increase dosages, and things like that. So mu receptors are a big problem. For us in psychiatry, that bullet point number 4 is very important. The conditional place preference. So you'll find that people tend to gravitate towards where they will very easily acquire the substance. Why? Again, it's because of the reinforcing effects that are driven by the mu receptors. And then, of course, you have the delta, similar to the mu receptors, but less reinforcing. But still, it plays a reinforcing property. So that means if you should combine mu receptors and deltas, you've got yourself a potential addiction. The last group of receptors is what will help you, in fact, to fight. It will attempt to fight the other two and play, an opposing effect to the reward that the mu receptors and the delta are giving you. But that, oftentimes, is not quite adequate. So, what happens when somebody is administered opioids or opiates? Well, if you give somebody an IV form of any opioid or any opiate, the first thing that they are going to feel is some warm flushing of their skin. And then they are going to feel what the patients will describe to you as a rush. It's an extremely sensational and beautiful feeling. It's nice. So when the patient that was talked about earlier, keeps demanding for these drugs, it's because it's nice. When it's administered, he feels nice. It is not nice for everybody. Some first-time users may instead react quite negatively with nausea and vomiting, and they may never ask you again for opioids. But the opioids generally, as has been described in the previous presentation, they usually have some euphrogenic effects. They have analgesic effects. They are sedatives, so people can actually die from these opioids. Because they are CNS depressants, you're likely to depress somebody's respiration to death. So, if there are certain behaviors that these patients exhibit because you've given them an opioid, what is it that the doctor needs to look out for? You need to look out for a pattern. Opioid dependence is not a one-off. You need to look for a pattern of certain things, and these are some of the things you could look for. Look for a pattern in a patient who frequently runs out of scripts or prescriptions for opioids. If they keep telling you, I lost it, and they've come to the pharmacy or to the clinic, you be careful. If he loses it more than twice, that should be a suspect patient. Look out for a pattern in patients who is on a high dose and keeps increasing that dose. Suspect opioid dependence. People who are injecting medications suspect that if they are on opioids, they are more likely to abuse it and be dependent on it. There are patients that will physically threaten nurses and doctors. Shouldn't you write for them a prescription? In one of our liaison services, just before the close of the year, a gentleman came to the casualty there, and he needed his prescription of pethidine. And then he got violent with the doctor who was on call. So when they are dependent, they can become unpredictable. You need to look out for such patients. Look at patients who alter or steal drugs from other patients. The patient who was described earlier knew everybody and what they are on in the ward. He's been there a long time. Maybe he's even the chairman on the ward now. So there is no telling that at night he will know exactly who to target and how much to take. Obviously, addiction doesn't come from the blue. You will have tried something before you got to this place. So people who are addicted to alcohol and to other drugs, those will have issues. There are many problems that are associated with opioid use, but the most prominent problems are associated with things like heroin and heroin dependence. But not everybody who uses heroin or morphine gets dependent on it. In fact, maybe about 1 in 4 will develop some dependence from regular use. But still, you do not want to be giving large amounts in short periods of time, because they will get dependent. And how do they get dependent? From the 3 opioid receptors we talked about earlier, these can mediate the effects of opioids. They mediate this effect because they belong, the receptors, to a big group of protein-coupled receptors called the G protein-coupled receptors. Now these G protein-coupled receptors, if you ever go through biochemistry, they enjoy talking about this group. For psychiatry, they are interesting in the way they work with agonists, in that they inhibit neuroactivity. So if you needed to feel a little bit calm and relaxed, you probably want something that is going to act on those groups of receptors. And the opioids are very happy to do that for you. So, we've already mentioned that they are involved in pain management, the pain pathways, but they are also involved in response to psychoactive substances. Now notice that up to this point we haven't talked about addiction and the mechanism for addiction, and we only bring it up now precisely because the opioids don't actually need your reward pathway. They don't need your ventral tegmental area and your nucleus accumbens to get you dependent. That makes them extremely dangerous drugs because they use a dual mechanism to get you dependent. Most other drugs of abuse require the ventral tegmental area and the nucleus accumbens to create your reinforcing effects. Other peptides that we've mentioned before, the endogenous ones, their job is being well documented in regulating stress responses. And again, you can hear that stress is coming up over and over. When the person with sickle cells is in pain, definitely they'll get stressed, and then you're pouring a lot of endogenous opioids in there to try and ameliorate the pain, and that may sometimes not be enough. Feeding, mood, learning, memory, all these are issues that can come from the endogenous opioids. For us in psychiatry, this is the area where we get very giddy with excitement. When you develop tolerance and withdrawal, which can happen in opioid use, you have started the long journey to addiction or to dependence. In fact, desist from saying anything is a dependence unless you can demonstrate these 2 things. Desist from saying your patients are addicted to the drug, addicted to morphine, unless you can demonstrate that over a period of time, they need increasing amounts to get the same effect that previously a low dose could give them. So if the pain could have been managed at a much lower dose of morphine, and now you need so much more morphine to manage the same pain, then you're demonstrating tolerance. So you get suspicious that we are now starting to develop dependence. But if the patient you withdraw the opiate and they get dysphoric feelings, they get into withdrawal syndrome, then without even other symptoms being there, that person is definitely dependent. So in your practice, you want to be looking out for tolerance, you want to be looking out for withdrawal to gauge how, dependent on the substance your patient is. And these sets of slides just talk about that. But I'll just stop here for a bit and just talk about the acute desensitization and the long-term desensitization that Dr. Bagaya also alluded to. The opioids So you administer the opioid to your patient. Immediately they get that rush. In fact, they have started to develop sensitivity to the substance. In the acute phase, within minutes really, of you administering the substance or the opioid, they will develop acute desensitization. So you've pretty much started to increase the dose by giving just one. Because what that means is that the next time you give, they're a little bit less sensitive to it now. And then you have to increase a little bit. So we are in that catch-29 where you want to manage the pain, but then you can't do it without increasing the doses. In the long term, that desensitization can last for hours, really, and even days. We talked a little bit about withdrawal. You want to be looking out for that. Every time you cease to give a substance, if the patient should react with dysphoric symptoms, then you know that we have developed dependence. For opioids, that withdrawal symptom can take quite a bit of time, almost up to 2 weeks. That's an extreme amount of time for people to be experiencing these things. So the moment that you notice symptoms of withdrawal, it means that we have to manage this patient for dependence, for opioid dependence. This happens usually because of neurobiological adaptation, because the patient has developed tolerance and now the receptors have become habituated to the substance, so you may need to increase dosages every time that you give. The caller asked me to dwell here, so I decided to do pharmacological treatment of opioid dependence and not management of opioid dependence, in which case I would have gone to give you even the psychological managements and the social managements. So we'll just, for purposes of this talk about pharmacological management. So these are some of the substances that we use in managing opioid dependence. I'll tell you that it's a difficult journey to walk when you are dealing with somebody with opioid dependence, because you get this kind of revolving door phenomenon. And relapses are very common. So the patient that you treat, he moves out, he'll come back with the same problem. And sometimes doctors find that quite frustrating. Methadone is the gold standard really in managing opioid dependence. It's the gold standard which Uganda does not have. Yeah. Uganda doesn't have it because we tend to move a little bit slowly or slower. We should be having methadone clinics all around Kampala by now, but we do not have them. If you want methadone, you'll have to order for it from Mathari, from Nairobi. But methadone is good. It's an opioid itself. It's a synthetic opioid, and it's an agonist. So it's pretty much like your morphine and your heroin and whatnot. So it's doing the same thing. It acts at the same receptors as the other opiates. By doing that, it helps you to eliminate the withdrawal symptoms of the other. The great thing about methadone is that you don't have to take repeated doses in the same day. It has a half-life of up to 24 hours, so you don't have to repeat the dose until tomorrow. So you can't have patients walk in as outpatients and take their dose of methadone and go away, as opposed to morphine, which you'll have to give every so many minutes. It's taken orally. It will usually leave no cognitive blunting. It doesn't make you, it doesn't sedate you. So people can go back to work after getting their methadone hit. And it also helps to reduce relapses, and it's quite safe and effective. The other synthetic opioids is the LAM, which should be a little bit better than methadone, because it has even a longer half-life than methadone. So you would only need to administer this one about 3 times in a week. So the patient doesn't have to come to you every day. In the developed world, buprenorphine is taking the world by storm, and it's being considered for primary health care to be given out there in the lower health centers, because it doesn't need much monitoring. It has a long duration of action. It's highly safe, and it's a partial agonist of these mu receptors. But when buprenorphine binds to mu receptors, it binds extremely hard and takes quite a long time to dissociate. So in that sense, it makes buprenorphine maybe even a little bit better than methadone, because it will take a long time in the binding site and you may not have to repeat the dosage. What happens when somebody has got an overdose? Like the gentleman that is now self-administering. Sometimes they might get an overdose of the opioid. Your drug of choice should be naloxone, because it's a competitive antagonist, and it's very good in treating opioid overdose, which you will know by someone's fluctuating level of consciousness, especially those who have been using opioids. They usually have constricted pupils, hypoventilation, and moist skin. So you use naloxone to manage that. But while you use your naloxone to manage the overdose, you also have to do other things as a doctor, because you've just got into an emergency situation when somebody is in an overdose of opioids. So you make sure you monitor their airway and breathing and circulation as you continue to give your naloxone. Usually when we give this naloxone, it's like a Lazarus effect. Patients who are there, you know, they are semi-comatose, they'll get up and start talking. So that's what you're looking for. So you keep administering until such a time that your patient gets up. But also keep anesthesia in the loop, because you might need them to come and take that patient for further care. Another drug, what we now use, now I have to brag a little bit. We have naloxone, we have naltrexone, so I can brag a little bit. Yes, we don't have to go to Nairobi for this. With naltrexone, you're going to have to wait until the person is at least 1 week free of the opioid. That's the downside. Same thing with when you're using it to manage alcoholism. You don't want to start it while they are still using the substance. You're going to wait, because this is a drug used for relapse prevention. It is an antagonist, and it's really effective, and usually lasts about 1 to 3 days in the bloodstream. You only start after you've managed them and done the detoxification. The best thing about naltrexone is that there is no potential for addiction. So, another great thing about it is that because it's an antagonist, it blocks the thing that you're paying money for. So in effect, we are helping you to save money. So when we block your drug, then your money is wasted and you won't want to waste it next time. Some places have now started to use heroin-assisted treatments. And again, this is more specific for heroin and the like. In summary, we've talked about these substances which can be used as replacement therapies for opioid dependence. Feel free to look at them much more and come and we discuss them a little bit more. But a few diagrams here that you will take and see that demonstrate to you the effects of methadone versus say heroin or morphine, its long duration, low euphoric effects, and so on. So I beg to stop here, and I'll take some questions if they're there. But this is what patients will report to you about the goodness of some of these drugs that we do give as replacement. They'll prefer methadone to buprenorphine because buprenorphine really just tapers off at some point. No matter how much more you take after that, you'll get no effect. Whereas methadone has a slight potential for abuse as well, because its euphoric effect can just keep going up. So thank you very much.
medications are doctor shopping or go to multiple sources for medications? And the second question is it possible for a patient to get medication for Nairobi if you were to prescribe it?
Second question is a yes. The first question is that there's a lot of doctor shopping in this country. Patients will move from one doctor to the next, and in fact add even a few bad things about the last doctor and why he didn't understand him. They can be quite convincing, especially when they're at dependent stage. They are quite convincing, and they will look for the kindest possible doctor. And then they also study the seasons, the time of the day, the time when the more novice doctor is on call. Probably that's in the evening hours. So they won't come in the morning because Professor Mayanja is there, Professor Biachika is there. In the evening, probably the intern is there, and they're more likely to believe the pain. I'm sorry? You know, when I had recent,
the question is,
what did I mean by heroin-assisted treatment? In the past, my seniors, like Professor Mayanja, used to keep for us a bottle of rum down there in Casualty. That rum was supposed to help people who had come in withdrawal state of alcohol. So we'd give them some alcohol. Kind of the same thing here. So somebody has come with a heroin problem, so you give them a little bit more heroin, except this time you are the one controlling it. Yeah.
So one last question.
Yeah.
What could we have done differently for the patient who was presented today? Professor Biachika asked the question, why did we continue to give the patient ibuprofen when we knew that he's dependent, when we thought he was dependent? What could we have done differently?
I think the main thing here should have been documentation, first of all, that because I understand that the team here works in a bit of a segmented manner. So some group comes in the morning and makes a prescription, and another will come in the afternoon or evening. Proper documentation is important so that the subsequent groups of doctors that come in know exactly what the patient received and why. But the second one could have been just what was on Professor Mayanja's slide. We could have talked to this patient a little bit more. Just talk to him as a human being. And perhaps the best person to have done that would have been someone like a nurse. Somebody who can talk to him at a level where he doesn't feel like he's inferior. That sometimes gets you to know exactly what is going on. It would have been nice if you could have demonstrated to me that he was dependent. But from your discussion, it doesn't seem like we had reached the level of dependence or something like that. But he did have some features to get us concerned. The selling, the administration, the self-administration. Those are things we should be concerned about. And usually you address them head on. You don't want to beat about the bush when you suspect there is abuse of drugs.